Welcome to Northern BC Narratives on location. Today, I have another amazing person with me by name of Shalina. Shalina, hopefully I said your name right. It's a pleasure to have you on the show. Thank you for coming. I know you're busy. Talk about yourself and what you do.
So I'm a certified podorthist, which is a foot specialist. So when someone's foot hurts, they come to see me and I try to figure out why it's hurting and what we can do to make it stop hurting. So sometimes it's exercises, sometimes it's like stretches, sometimes it's different shoes, sometimes it's a custom orthotic. So that's what I do.
Okay, so how do you get in? Talk about, so how did you get here? Did you when you were a kid, was something you were passionate about? What is the story here?
So I always wanted to do something that was to help people, but I wasn't really sure what. Either people or pets. But then I was like, well, if you're a vet or something, you have to euthanize animals. So I was like, I can't do that. So then I was thinking of something like physiotherapy, and then I was working at a specialty shoe store when I was going to university, and I met this podorthist that was a podorthist and athletic therapist that had been here for like 100 years.
100 years?
Well, not really.
100 years?
Really
100 years. Almost meant for it. Almost meant for you. 100 years.
Yeah, and so,
this guy must be like, okay, go ahead.
Well, I mean, So his name was Brian Ferentz, and he was saying how he wanted to train someone else to do this. And it was sort of a thing where, I mean, I already knew because of the shoe store and stuff how much the right shoes would make a difference. So we would have people like limp in the door, and then we would fit them with a wide shoe that fit their foot and measure their feet and stuff. And then they would like walk out and they'd feel so much better. And I was like, this is something I could probably do. So then I went and did some like just days to see sort of what he was doing. And I thought it was really interesting because it's always slightly different.
What would you see?
So when I was just with him, it was things like plantar fasciitis.
What is that?
That's when you have a strain to your arch.
Okay, we talk about it because nobody knows about this stuff. I didn't even know that. It's like, I feel like a spaceman when you said that. I was like, what is that? I'm trying to figure out. I'm going my dictionary. There's nothing.
It's one of the most common things. So itis is a medical term for an inflammation, and plantar fascia is your arch. So
what is arch?
Under your foot.
Okay.
So it's like there's the toes, there's the heel, and then there's the arch. And so that's a really common thing. But when I was with him, what I noticed was there was nobody really doing anything for diabetic feet or people with...
What is diabetic feet? You're talking to people that don't know anything about this stuff.
I'll get into it in just a
Okay,
second.
good.
So diabetic feet, ulcers, and other things like that. So when people are diabetic or undergo things like chemotherapy and stuff like that, sometimes they get a condition called neuropathy, which means the nerves in their feet, they can't feel them. So you know that you're standing on the ground, maybe, but the feedback from your foot is kind of like, as clear as if your foot was this table. So you can't feel anything from your feet. And so what happens when you don't have feeling, you can get an injury to your foot really, really easily. And then there was not really a lot being done to help that. So what I do with an orthotic, for example, is I take pressure off that spot so the foot can heal. And then I always, tell people to check their feet and stuff. But when people get those wounds on their feet, they usually get a bad infection. And often what would happen is no one was taking the pressure off. So if you're standing on something and it's trying to heal, can't really heal. So then they would get repeat infections because you have an open wound on your foot and feet are dirty. They're on the ground, they're in shoes, they're sweaty. And then they would just lose their foot or lose a part of their foot, then more of their foot, then their whole foot. And so I sort of decided to do podorthics, like fix people that have injuries from running or every day, but then also to specialize in things like diabetic feet that have ulcers and wounds and people that are going to lose their feet, so we're going to try this and this and this to try to save their feet. Along with the help of the family doctor and wound care and all that kind of stuff, just to move that pressure off that spot so that the foot can heal. And then, there's a condition called Charcot-Marie-Tooth disease where the foot collapses, and instead of looking like this, the foot looks like that. So this part of the foot touches the ground, the toes are in the air, the heel is in the air, And those people tend to get big wounds here because there's so much pressure. And then so doing things like filling that and that for the foot and then cupping it and wrapping it. And then with the help of a shoe store, like somewhere like Timberline or Stride and Glide, finding shoes that we can fit an orthotic like that in so the person doesn't get a big wound on their foot and doesn't lose their foot. So yeah, I sort of realized that there was nobody doing that, and I thought, you know what, I bet you I can do this. And then so I, finished my undergrad, and then went and did the specialty training for this, which is, so you do, at the time, so right now there's a program from University of Western Ontario. When I was doing it, there wasn't, so you had to sort of cherry pick from nursing and medical programs and sort of go to a university and be like, hey, can I take these 5 courses out of your medical program? And then get permission. And then be like, okay, now I need these 3 off of this one, and then find a shoemaker that was willing to teach you how to alter shoes, because changing shoes is part of it too. So, and then there was the, 5,000 hours in the lab building orthotics.
5,000 hours?
Yeah, and then 3,500 one-on-one with patients. So it takes a while to get all the certifications.
That is a lot of time.
Yeah.
Oh my God.
Yeah.
So what was your undergrad? What do you study?
So I did sort of a mixed one. So I did international studies, which was my interest, and then I did some kinesiology, which was needed for this, because you have to go for what you need for your school, and then also if you're like, I want to learn 5 languages just because.
You know 5 languages?
Not fluently anymore. I know 2 fairly fluently.
Yeah.
I used to know Russian. I used to know a bit of German. I used to know Spanish and some Mandarin. Ooh, functional Mandarin.
Yeah, Mandarin, that's the tough. That's very tough.
Yeah, well, it wasn't too bad to speak, but I never was that good at reading it.
How is it? Is it hard to write? Because of the symbols, right?
Yes and no. I mean, it was the speaking, it was mostly where I got good at it. So, yeah.
So what international, was it relations? What was it?
International studies.
Why international studies?
Because I liked learning about the world. And, and languages. I've always liked languages, so.
What is your favorite language?
I don't know. I don't really like to pick favorites. They all have very different feels to them, so. Yeah.
What feels the best?
I don't know. I'm pretty partial to French, but that could be because I did grow up speaking French, so.
Parle français?
Yeah, French and English.
Oh, I like French. I really like French language.
Yeah.
It's like poetry, So when you were at the university, your undergrad, you were studying for what you're doing right now, right? So you were cherry picking, you said, right?
Yeah. So part of it was like because you need specific courses and stuff to be able to qualify for these other courses and stuff, and for the certification. Yeah. So I was doing those sorts of courses, and then and then I was sort of doing stuff that interested me, because if you're going to university, so many people do it just for
a degree.
Yeah, and the thing is, I don't think you get as much out of it as if you're also going with things that interest you. So, you can take your electives in...
Be miserable, right?
Yeah, well, you can take your electives in a boring field or something that you think is interesting. And usually, if you ask permission, they'll let you take stuff that isn't in your program. Yeah.
Well, that's amazing, yeah.
Yeah.
Because it's so dry, university is so dry sometimes, right?
That's why you go, I want to take this 4th-year course that I am not at all in that, but it seems interesting. And you do work harder, but it's more fun.
So what happened after that, when you finished the school?
That's when I moved to Victoria for a bit, because they had some of the courses I needed at UVic, and they didn't do distance for that. And then I was also going to SFU and UBC doing distance courses from them, and then at UVic. Because, I needed those courses, and they're like, no, we don't. You have to do in person, and they had labs that you had to be there for. And then I moved back to town, and then by that time, UNBC had their physiotherapy program starting, so I was able to, they were talking about starting it. So they were offering some nursing stuff too, so they had some like anatomy classes and stuff that I was able to take for some of my other qualifications, but yeah.
You made your own program. That's crazy.
Yeah, and now it's
Yeah.
a lot easier because you just do the University of Western Ontario. Everything is in one
Is
spot.
already-
You're not having to write to 5 different universities being like, I'm a good student, I promise I'll finish these courses. Can I like do this distance?
Yeah.
And then, have them be like, yeah, we can figure out a way to do it distance, or no. Or yes, but you have to still come here for the labs, which, I mean, that's kind of what UBC did. So I would have to go to the mainland and do stuff. And then, then I came back here and then did my hands-on hours with Brian. Because a lot of places don't actually build their own orthotics. So you can...
Why not? Why not?
They just send them to these big, what they call puppy mills, which is a
Puppy,
really
what's
bad
it
name.
called? Puppy mill?
Yeah, I know. Isn't that a terrible name?
Puppy, what's going on in that
what
factory?
it is it's where they build orthotics en masse.
Puppy
So they
mill.
have all the casts are sent there, and then the people get a sheet that explains how an orthotic, like what features that they want in the orthotic. And then you have this person that is not a fully certified podorthist, just building orthotic after orthotic after orthotic.
It's like a machine.
Yeah, sort of. So they would have all the materials there and they would press it and stuff, but it's people doing the work, but just like they haven't seen the patient and they're just going off a cast in a paper. And that was always I didn't like that as much. And then so with Brian, he actually built everything by hand. So what you would do is you would see the patient and you'd see whatever, he only did mornings, built in the afternoon. So he would see the patients in the morning, build the orthotics in the afternoon, and then they would be ready like for a couple weeks from then for pickup. So you'd start them like that evening. And then I thought, you know what, this is kind of good because if you've seen someone, you can, be building an orthotic and be like, you know what, actually, I was going to do this, but I don't know if that's going to work. Or sometimes you're there and you're like, I have an idea. We're going to see if this works. Or you find a little scrap of material that, like, it's a kid and the kid was like, oh, my favorite color is pink, and oh, you only have this color for a top. And then you find like a little scrap of pink and you go, oh, I can make it pink. Just stuff like that where you can sort of personalize it a bit more. And especially when you're doing like the diabetic patients and stuff, you just have more, like you know what you've seen, you remember what things look like, and you know what shoes they're wearing, and you know how much space you can take up and that kind of stuff. So I learned how to do all the hands-on building. And it's sort of, when you build orthotics, it's kind of a mix between the science and the art. So the science is knowing, what you're offloading, how to do it, what to do, what not to do, degree of correction, all that kind of stuff.
Talk about it. No, just
Yeah,
get into it.
Changing it.
So what do you mean degree?
So let's show you. So like, different ones for different problems. So if this person had a very collapsed foot, it was broken, and so their foot was sitting kind of like that, and then so we took their foot and we made an arch and we tipped it to the outside so that way this part can heal. So this is, 4 degrees correction here and here. And I know this because I've been doing it for so long.
You're like a laser.
Yeah, I can see it and tell.
Superwoman vision, like.
And then this would be, if it had no correction, the heel would be totally straight like that. And the front would be down further. And that's where the art part comes in, right? Is being able to take the orthotics and take the foot and then mold and build on that. This is for someone that had a big toe that was really sore, so the ball of their foot. So it's really squishy here, really firm here. And then, it's, a bit of correction, mostly in the ball of the foot. So their foot was sort of like that. The heel was straighter than the toe part. So we tipped them out and their big toe was sore. So we were taking all the pressure off the big toe and the ball of their foot with that one. And that's the art part.
Oh, that's crazy.
And then this is where, when you run a lab, which we do. So right now with Roxanne and I, we'll see patients Monday, Tuesday, Wednesday.
Yeah.
And we usually start the orthotics that day. And then we finish them Thursday and Friday because when you hurt, it's not fun to have to wait. So we always have the things ready the following week.
That is amazing. Nobody does that.
No, everywhere else you have to wait 6 to 8 weeks.
You die by that time. You have to chop your foot off.
And by the time people finally come in, most of the time they've been in pain for months or years.
Yeah.
So it's like just adding to that extra weight. And we can be like, You know, and we've even had cases where people have been in a lot of pain and they're going on a trip next week. And so we've rushed the orthotics and stayed late and had them ready the following day for them. And this one is, it was designed to fit in a sandal. So the straps of the sandal sit here, so that's why the sides are finished, because they're the parts that peek out. And it was for someone that had claw toes. So this beige material here squishes under the toes. So, and it sort of will keep that toe imprint. So after being worn for a while, each toe would have a little home. And then it has this black because that it matched the shoe. So yeah, you can sort of change how you're building it when you've actually seen the patient, you know what they're wearing, and customize it a little more, which is kind of nice. And the other podorthist is, she's newer, she's only been, I trained her and she did all her courses and stuff, but the hands-on stuff I did. And she's been working with us for about 2 years now, and she's getting better at the building, but that's the part that takes the longest.
The longest, eh? Like, you're so passionate about this. Like, you love it, right?
I've been building orthotics for like a very long time.
10 years?
More than that, like 15, 17.
17 years.
Yeah, because I started with, you know, the building while I was doing all the courses and stuff. When I moved back to town and was taking the last of my courses, I was getting my lap, because 5,000 hours is a lot to get.
That's
Takes
a lot.
years.
Like, it's 5,000, it's like crazy. Like,
Yeah. You know, and that's why, yeah, and it just, you know, makes sense to me that if you've seen someone, that then you do the hands-on to build stuff. And they're flexible too, so we can change them. And this one is for a little tiny kid. We usually don't do them for really tiny kids unless they have a really big problem.
Yeah. So what's the problem?
So sometimes we'll see kids with chronic pain, which is it's never good to see, but then when you change what their foot does, it sometimes helps with that pain a bit, just because now the pressure is the same everywhere. So yeah, it's not great when you have to build tiny little ones, because you know it's a big problem, but they're also really cute.
I know. So. Talk about some of the materials here. Let's go with this one. So what is this?
That's a heel plate. So this is
a heel plate. What is a heel plate?
So it's to strengthen the back, and there's a few different options. So some have grip.
Why? So it doesn't
slide. This one is just, it's a material that's got a little bit of a stick.
It's almost like a suede, right?
Yeah, so it doesn't slide, but it's full length.
Yeah.
And sometimes when the bottom of the shoe is really, really grippy, we'll use this stuff because it makes it easier to get it in and out, because this is really smooth.
Yeah.
So if it's like Red Wing boots, if you take the insole out, the bottom is a kind of rubbery that's really grabby. Yeah. So if you use something like this, it just catches. Or this, so that's where you use something like this one. It's nice and smooth, and it goes in and out easily. This material is, it's a softish material that heat molds as you wear it, and it comes in so many colors. So a lot of people only get black, and I discovered that it comes in so many colors.
How many colors?
Oh, like hundreds of colors.
Hundreds of colors.
And so I always get 5 or 7 or 8, and I try not to get black because that's boring.
Yeah.
So I always get something bright and exciting.
So
it makes it easier too to find. If you leave an orthotic in a shoe, if it's black, it's a lot harder to see.
No.
If it's blue, or like if you have visual impairments, the high contrast of the blue and white or the black and white, it's easier for you to see where it is. So yeah.
Okay, so then what is this?
This is cushion cork. So it adds some firmness. So if you sit and you poke here, it's really squishy.
Yeah, it is.
Yeah, and then if you poke there, not so squishy.
Pretty hard.
Yeah, so it absorbs shock still.
Yeah.
And that's what I like about the cushion cork. It absorbs the shock, but it sort of redistributes the pressure. And if you have a big toe that sits lower, squishy there, firm there. Now the pressure across the foot is the same. Because this toe sits lower, we're raising the ground up to these ones.
Okay. So this is a harder material, right?
Yeah.
And then this is?
That is, it's called PPT. It's just squishy.
Is it a mold or what is this? Is it a pouring material or is it a foam?
It's a foam. It comes in a roll,
Yeah.
and then we cut it. So some places do preformed things, like preformed means it comes already shaped like something.
Yeah.
We don't. We use big sheets, like
Yeah.
big sheets, and then we cut it to size.
Yeah.
So we find that if someone has like a really, really wide foot, we can cut a wider material. If we want to wrap the foot, like come up really high on the side, we can do that. And then we can make it to fit a lot of different shapes.
So this side is shiny. How do you do that? Do you heat it up or how
No, that's just what it looks like.
Okay.
This is the part that hasn't been ground. This part was ground.
How do you ground it?
We have a giant sander.
Giant sander.
It's like that big. It's a very expensive machine. But yeah, and if you're not careful, it eats your fingers. So I have
serious?
special gloves that I wear so that I don't grind my fingertips off.
Have you ever grind?
Yes,
What
that's why I
happened?
have the gloves.
Tell me about it.
So sometimes you're grinding the orthotic,
Yeah.
and then the machine, because it sands really fast,
Yeah.
and it has really rough sanding belts,
Yeah.
and then it takes the orthotic and throws it on the ground. And if
Oh.
you don't pull your hands away fast enough, because your hands are right underneath it, you're
Yeah.
using them to stabilize it.
Yeah.
So if you're holding it kind of like this and pushing up with your fingers, and then this is suddenly not there, your fingers are going right in, which I did, and it hurts. So then
How
we
many
got
ti-
mechanics gloves.
How many times that happened to you?
So I've done a couple minor ones, and then I did a really good job with all my fingertips.
All your
last
fingertips?
Year. Yeah, that
How?
was sore.
What happened? How far did you go?
Oh, you take it off pretty quickly, but
Oh my
it goes really
God.
fast.
Let me see it. Let me see.
So they look fine now.
Okay.
Yeah, they're okay now. But
There's no scars,
last
right?
May, no, it's fine. Last May it was, then my brother was like, oh, you know what, why don't you use mechanics gloves? Because mechanics cut themselves all the time, so
Yeah.
they need something that protects their hands, but they can still feel things. So he got me mechanics gloves, and they work so well. I can also touch hotter materials with them. It's good.
Mechanics glove. I should look into that. Oh. So what is this material here? So So you got this.
Yeah,
You got
and this is-
what is it in the middle? This
That's
little-
the same as the top, but a different color.
So why is it here? Because
So
you're building it, I guess.
That's
right?
a metatarsal bar, so that takes pressure off all the toes.
Say it again. What is it called? Middle.
Metatarsal bar. So this one has one too, this one doesn't. So you see how this one's sort of smooth onto the ground here?
Why is it called metatarsal? Meta.
Yeah, because the metatarsal heads are the ball of the foot. The pointy, just under the toes. So there we go here. Ha, look, it's a foot. So these are the metatarsal heads.
Okay.
So if you go to the foot, this is, I lost a toe, it's very sad.
What happened?
Probably when you get too excited and you're showing someone something, and sometimes you accidentally, I think someone broke their toe, and I was like, your toe kind of did this, and then it came off, so it broke its toe. But yeah, so this is the metatarsal head, or the ball of the foot. You'll hear people say, oh, the ball of my foot hurts. And if you look at it, it's pointy.
This is crazy.
Yeah,
I never
it's-
seen it like this. Now you're showing it to me in a different. I never seen.
Now I have this foot.
Oh, look at that.
So if that's sitting on the orthotic,
Yeah.
this is not the right size for it. If you lift up just under this spot here,
Yeah.
you take those off the ground a little bit.
The metatarsal.
Metatarsal heads, yeah. And then that's what that ridge there and this line there is. So it's sort of lifting it so that it takes some pressure off there. And there's a fat pad that sits under that bone, but as you age,
Actual fat.
squishy. Yeah,
Okay.
it's why it's squishy there.
It's called.
Yeah, those are fat pads. So the fat
This is not
pad,
meat. I thought it was meat all the time.
no, it's fat.
These are fat.
Yeah. So then the fat pads over time,
Yeah.
with lots of on feet, shift forward.
Yeah.
And if you put pressure right here, you're also pulling them. So you're taking pressure off with the height, and you're gently pulling that skin so that that fat pad sits back under the pointy spot.
So wait a minute. You tell me as you age, this thing moves around.
This stays, but the cushion moves. The cushion goes forward and disappears.
Oh my God.
Because feet are like, you know what? No. We were designed for use, but no, we don't feel like it. Yeah. So this
At
is
what
my
age
foot.
this starts to happen?
Depends on the person.
Okay. If
Some
they're-
people are really bony and their fat pads go away very young. Other people, when they're older. It's very individual. And it's a genetic thing. So what you have to do is look at your grandma, grandpa, mom, dad's feet, figure out whose feet look the most like yours, and then you know what's coming.
Oh God.
Yeah, I know. Oh, one of my parents had really bad feet. Then start wearing grandpa shoes now and save your feet. Because that's the other thing is a lot of people will wear like slip-on shoes that have no support that you can, you know, wring out, and then they don't have a lot of cushioning, they don't have a lot of support, and then they overuse their feet. And some people go, well, but, you know, it's more natural to be barefoot. But there's nothing about the world we live in with, you know, hard floors everywhere that is natural. Like, we're not designed to live on concrete jungles. We're designed for, like, you know, other surfaces that are softer, like sand and dirt and like fields and that kind of stuff that haven't been run over by hundreds of people and haven't been driven on by heavy machines and all that.
It's not flat.
Yeah, it's not hard. Yeah, and so if that's the other fun thing, if we're building an orthotic, we take an impression of the feet, so we take a foam block, like flower arranging foam, but a little
I know
different.
what you're talking about.
Yeah, and then we take a foot and we hold the foot sort of straight, and then we do like a stamp, because then that foam holds it, and then we pour it with plaster and we make the foot.
Oh, okay, that.
Yeah, because if we use the patient, they just wiggle way too much. You know, they just don't stay still upside down in our lab for 3 days for some reason.
Whose foot is this?
I removed the initials. I don't know. But then we take this, we take our piece of material that's flat that we've cut, stick it on. We have a suction machine, which is really fun to use.
So, suction machine.
It's like square, and it has a bladder, so like latex on the top. Then it's attached to a little motor, and you close it, and then you turn it on, and it takes all the air out so that it sucks the shape right onto the cast. So it's like,
oh, okay.
And then you let the material, because you have to make it hot so that it's floppy, because these aren't floppy enough. So you heat it up until it has no structure, put it on, suck it down, and then you cut it to shape from just like a rectangle.
Is this a product? So you have to make this, right?
Yeah, that's the cast.
Where's Andrew?
Oh, that's not Andrew. It was just.
No, there's nothing on it. I'm just.
No, I think that was a woman's foot actually with the size. But yeah, just.
This is a nice feet.
It's a fine foot.
So what is wrong with this feet? Talk about it.
I'm not sure what was wrong with this one, but probably plantar fasciitis because we made the arch. Sometimes we do what's called carving the arch, where we make the arch extra high, and it looks like that's what we've done here. So with plantar fasciitis or a strain to the arch, usually you'll do different shoes, a really high arch so that when you're walking, your foot doesn't move like that, so it doesn't put pressure through your arch. So you make the arch really high on the cast, and then gentle stretches and stuff. So yeah, you fill that, and then and if it was pain in the ball of the foot, I mean, having a high arch is also helpful, because if you fill here, there's less pressure here and here. Yeah, so that's my lovely cast. And usually with these, after we see a patient, we pour the cast right away, but we'll also do what's called cast dressing.
What is that?
So there's 2 ways of doing it. So either in the foam, say if someone has a bruise to their heel here, and it hurts whenever they step and it feels like a toothache at night, like a throbbing pain, we figure out where that most painful spot is, because that's part of what we do, is we poke around on feet until we make someone jump. Then we make a dent by taking that foam and pushing a hole in it so that this gets a giant lump on it, like a tumor. And then when we mold that on, if we put a lump on here, it's a gap on here. Because, you know, whatever's, it's the opposite. So whatever's down is up. And then if it's like they have pain to the band that's here because it gets too much pressure, we make a groove. Or if they have what's called a fibromatosis, which is like a lump on the arch. Some people get them because their bodies are like, you know what, I want to put this material here. And some people get them on their hands and their feet.
Yeah.
So
what is it? Is it like a cartilage or?
It's just fibrous tissue. So it's just like the same.
What is fibrous tissue? What is it?
So it's the same sort of stuff like the arch is made out of. So it's just the stuff that sort of attaches it. So yeah, so some people will get, so with your hands, if you feel how your tendons move.
Yeah.
So sometimes on the tendons, they'll build it's almost like a scar tissue.
Yeah.
So they'll just build up more material, and then it makes it so it's sore because, I mean, now you have this thing that sticks out that digs into the ground if it's on your foot. and into shoes and stuff. So yeah, that's just extra material. The other fun thing is ganglions, which are...
What the heck is ganglions? All these new
they're
things
like-
I'm learning. Oh, I'm getting educated today. I'm in school today.
They're kind of like water balloons,
ganglions.
but
Ganglions.
made of
Yeah.
like fluid and stuff from the foot. But they feel, if you've ever felt one once it's been removed, it's like poking at a water balloon. They also can pop sometimes. But yeah, if you take pressure off of them,
Yeah.
they become less swollen and then sometimes just go away. So yeah, if you have one in a spot, say you have one there on your foot, again, we would press the cast,
Yeah.
make a lump there.
Yeah.
Or the other thing we can do is, we have some people that do what's called pronation, so they walk on the inside of their foot a lot. So say if this was a normal foot,
Okay.
they go like that. So they're sort of, when you see people walking on their ankles with their knees knocked together, and we'll do what's called a gate plate, where we fill this spot, and then we tip the whole orthotic,
Yeah.
but under the big toe too. Because if we tip this spot too,
Yeah.
we get even more rolling out.
Yeah.
So that's another fun thing is,
So what happens when you do that?
then if they pronate a lot, we get it so that their foot, instead of being like this, way pronated, is just kind of a little bit, and then their knees are not as knock-kneed.
Oh, yeah.
Because if you have knock knees, sometimes that causes pain. Because your tendon, instead of going up and down, goes like that. So your kneecap moves at an angle if you have knock knees. And
Can that cause pelvis problem, back problems, and things like that, or no?
So with research with things like orthotics and hip and back pain,
Yeah.
it's very mixed. What we found is for like a lot of injuries and stuff, doing orthotics for back pain, for example, helps with recovery.
Yeah.
But we don't know if it's because we're changing alignment,
Yeah.
or if it's because sometimes when people get stuff like the orthotic and stuff, they're just more likely to become more active.
Yeah.
And the more active you are, the better the recovery. So you want to be active without overdoing it. That's always the key is
Yeah.
you push yourself so that it hurts, 1 or 2 days after, you get a little more pain, that's okay. But if you push yourself for 4 or 5, or so much that 4 or 5 days later you're in more pain, you've done too much. And, with recovery, you want to be pretty active, you want to push yourself a little bit. And so the question is, if someone has a back injury, is it that getting brand new shoes and new orthotics and all that kind of stuff is making them be a little bit more active? Or is it that, you're changing how everything is lined up and you're changing how the hips sit and everything, or is that what's causing the pain? And we don't know yet. So it's and same with hip pain with orthotics. The really interesting thing is for women, about 1 in 4 have a decrease of pain if you do orthotics in their
Yeah.
sort of hips, depending on their alignment.
Yeah.
With men, it's totally random. We have no way of predicting who is going to help and who it's
Yeah.
not. So it's certain things you can say, yeah, I take pressure off of that. It makes it way better,
So
like the knee.
So for women, it's more beneficial, you say, almost.
For hip pain,
Hip pain.
yeah. For knee pain, everyone. Oh, and that's the other thing. So knee arthritis, everyone gets that.
Oh, God.
Yeah. Are you looking forward to your knee arthritis? But what we've found is that with knees, because
Yeah.
they're set up kind of like this, and there's
Yeah.
3 compartments.
Yeah.
There's medial, lateral, and then patellar, which is just
Yeah.
right under the kneecap. And what we've found is that if the arthritis is either one side or the other, and we build an orthotic, so say they have arthritis in the medial compartment,
Yeah.
so here, and then we take their foot and we tip it out and we change how their knee's sitting and open it like this, it takes their pain away. Same with if the arthritis is on the other side and we make them knock-kneed, because we change that pressure. Yeah.
Would it shave some of that cartilage or no?
No, it doesn't. We don't change anything
Yeah.
functionally in terms of like shaving cartilage or doing anything like that. We
No.
just change
Yeah.
how that lines up, and it takes the pain away.
So the way it lines up, would it be harder on the other side of the
Of the knee,
Yeah.
it puts more pressure there, but
Yeah.
that's not the damaged side.
Okay.
So usually people can be a bit more active without
Yeah.
pain, and most of the time,
Yeah.
when you have arthritis in your knee that's so
Yeah.
bad that you're losing the ability to do things.
Yeah.
Even if you're on a knee replacement
Yeah.
wait list,
Yeah.
that's quite a wait. So and keeping strong and active while you're waiting for a replacement is really important because the better your muscle tone is and the more active you've been, the stronger your muscles are, the better your recovery. So that's where doing the orthotic and moving that pressure so that, you know, people can continue to hike, they can continue to walk, they can continue to play pickleball, that kind of stuff, because pickleball is really popular.
Is it? What is pickleball?
It's like...
It's not that one that they throw and you have to run away, right? I remember that in high school. It was horrible.
No, it's like...
You're not talking dodgeball.
Yeah. No, it's not dodgeball. It's like half squash and half tennis, kind of?
Yeah.
Or like, it's like table tennis, but giant, kind of. I don't know, it's weird.
I have to Google it.
Yeah, it's a weird sport. It's really, really popular.
Is it the one that you hit in the wall and if you're not careful it hits you in the face and breaks everything?
No, that's either squash or racquetball.
I think it's racquetball. The one, you know, you're in a closed room and you keep hitting the wall. That's like a suicide mission almost when you go in there, right?
Squash does it too, but a smaller ball.
Yeah.
The squash ball is less hard. But you're supposed to wear goggles for both. And I think people wear goggles for, at least I hope they wear goggles for pickleball. But yeah, pickleball you play against someone instead of a wall.
Yeah.
So yeah, maybe like racquetball against someone. I don't know. It's a fusion sport, and it's very, very popular. I think we actually, Prince George just built a couple pickleball specific courts.
I gotta remember this name.
Yeah, because tennis was really popular years ago.
Yeah.
There's tennis courts everywhere.
Yeah.
And I
but
think
it's so cold, right?
Well, but there's no snow.
Hey,
That's
in
how
the
you
snow,
tell.
you don't need a tennis ball. You just stick
make
some
it,
snow
No,
and
you skate in the winter. You skate and ski and snowshoe in the winter.
You do that?
Yes.
You know how to skate?
Yes, I don't like skating as much because it's always cold. But I like to snowshoe and I ski.
Yeah.
And
you ski. What kind of skiing are we doing? Competitive skiing or just like, the French skiing, they do cross-country skiing, right?
Yeah, we do cross-country. And then there are lovely trails at Otway that you can take your dogs to.
Yeah.
Dog trails, which is useful if you have a really annoying dog.
Yeah.
They can run.
Yeah. Get them tired, right?
Yeah, exactly. We also do make orthotics that can fit in those ski boots, which is not easy because they're very, very narrow. But, I steal the boot, keep the boot for a few days, and then build the orthotic into it. And then, and then the people can have their orthotic in their ski boot. But yeah, the key is you have to do the winter sports in the winter, and then the tennis once the snow's gone, and the snow's gone. Yeah. So now if you're really bad at tennis, you should really play because there's no nets yet. Yeah. So then you don't have to hit the net. It definitely will do well. And I've been told that they refurbished some of these tennis courts that were falling apart to be pickleball, which is good.
Pickleball.
Yeah, it's the other Pedorthists, her parents play it all the time, like multiple times a week. I think they do 4 or 5 days a week where they're playing 2 or 3 games a day.
This is going to be the new thing, isn't it?
It has been for a while.
It's not a bad idea to open a business now.
You retire and then you play pickleball all the time. Yeah, you should open a business with indoor pickleball courts for the winter. Yeah. And smoky days, because you'd do well with that,
So what is so this is the so this one is different material than this one.
Yeah, this is multi-cork.
What's the difference?
So this one is a bit brittle.
Okay.
So it's firm but brittle. This one is, so there's things called durometers, which is how hard a material is.
Durometers.
Yeah.
I'm learning so much today.
And
by the time I get home, I'm going to be a new person.
Yeah, you'll have forgotten it all. It's fine. But a durometer is it's a term that they initially came up with in a really weird way, and it was something like they shot bullets into things, and it was how deep it penetrated or something. It's very weird.
You don't shoot bullets into the soil.
No, I would not do that. It would be, my aim is way too bad. But yeah, so that's how they came up with the terms. And so this is like a 65 durometer, which is pretty tough.
This one is 60?
Yeah, and this one is about 60. And then let's see. And then the durometer for this one here, which it's the same color.
It sounds like French durometer, right? Doesn't it sound like French durometer?
Yeah, I mean.
Dur
and that's probably where that part came from.
Hardness,
then
I guess,
meter,
right?
Yeah, hardness meter.
Durometer is just...
And this one is 75 durometer, so this one's a harder material. And then this top is 35, so it's squishy. And then this one is even less, I think it's 20, because it's really squishy. And this stuff, if you tried to mold an orthotic body out of this stuff, it would just crack, because it's Like, you know the cork that like a Birkenstock or Mephisto sandal is made out of, those cork sandals?
Yeah, I remember those.
Yeah. The Birkenstocks are so popular right now. But so this is kind of what that body is made out of. So very similar to that. Theirs has more glue, but yeah, it's that kind of idea where it's got that firmness like that. Yes.
So how do you put this together? Like, run me through the process.
Layers.
Okay,
So
talk-
we
talk
would,
about-
we
talk-
would
talk-
take,
okay.
I would take my sheet, I would decide when I was seeing the patient, based on, you know, if they get blisters easily, how often they're going to use the orthotic, you know, if they're going to use it for running or
Yeah.
for dress shoes or like work shoes or sandals or whatever.
Yeah.
So say sort of based on what the problem is, what they're going to use it for, how much they're going to use it, and then I would base that and pick my materials. So I just have sheets and sheets and sheets of material, and then I would say, so say this person had a heel bruise, so you know, their heel was really sore. It felt like a toothache. It was doing that throb, throb, throb
Yeah.
when they were on their feet at night, and the more they were on the feet, the more it got sore. So I'd say, okay, I need something that has a bit of a cushion to it in terms of shell. So this material here has to have one that's a bit,
Bouncy?
has a bit of a rebound, yeah.
See, I don't know those words. I said bouncy.
Yeah, bouncy is the right sort of word. So I would probably pick like a V55 or something. So a little bit softer,
Yeah.
bounces back a bit more. It's not going to last as long as some of the harder materials, but you know, it'll still last a
Yeah.
couple of years and it'll make that problem, it'll address that problem. And then so we would cut a square bigger than the foot, heat it up till it's floppy, and all the materials have different heat up
Yeah.
levels, and they smell slightly different when they're heated up. So you know when they're warm.
Do you wear masks? Or-
We do for the grinding and stuff, yeah. Yeah, and when we see patients and stuff, we wear masks. And in the lab, we're always wearing masks and
No,
shields.
because if there is more fumes coming out of it, you have to have a special mask
Yeah.
probably, right?
Yeah, we have the N95 masks and all that kind of stuff, yeah. They're not comfortable.
No,
But,
no.
yeah, we wear them all
But
the
they
time in
protect
the
your
lab.
lungs, right? I guess.
Yes.
Like, yeah.
Exactly. Well, and you know, things like the glues are really strong too.
Yeah.
And we have things like a big fume hood for
Yeah.
the glue and gluing stuff.
Yeah.
So yeah, you take, well, first you would, you know, pour the plaster and wait for it to set, clean it off, clean the edges up. Then you would cut the material, heat it up till it's floppy
Yeah.
and the right, and
How-
that's
how
the
long
art
does it-
part.
How long does it stay floppy?
It sets within a couple minutes. So you have to know when it's ready, because
Yeah.
sometimes it'll pretend that it's ready.
Yeah.
And if you leave it in too long, it will
Melt.
start smoking.
Oh.
Yeah, which is not recommended, because then the fire alarm goes off, and then the fire rescue people come in.
Oh God.
Not very long.
Have you had those experiences?
Yes, it only takes like 5 minutes for them to come. It's amazing, and it's
Yeah.
like 2 fire trucks and 1 fire rescue, and then you're like, yeah, no one's here, and there's no fire.
The charge, right? They charge like $500 or something like that.
Only if you do it so many times. The
Like,
first
oh,
time
well,
they're
you-
like, oh. But yeah, so don't do that. Don't leave it until it smokes.
Yeah.
So you take it out when it's floppy, and depending on the material, it has to be in there for different amounts of time.
Yeah.
Then you put it on, close the thing, turn on the suction machine, and then you sort of hold it like that, the material, so that it sucks down exactly where you want and it doesn't shift.
Yeah.
So you've got your hands on that,
Yeah.
that suction press. Then it sucks it down, and then you can leave it for like 5 minutes or so while it cools. And you know, obviously in the winter when it's colder, it sets faster. In the summer when it's hot, it takes longer. And then you take the suction machine off and take it off, and then you cut it to shape, which is like there, and then you do sort of a rough cut. And then you put glue on, you decide what the
Yeah.
posting is. So posting is, so this is the shell,
Okay.
that's the posting. This is the arch fill. This is the top surface. So the shell is what the body of the orthotic is made out of. It's the part that,
What type of material is it? Can it be any material or?
so usually for the shell, because this is the part that's going to get a lot of force, but you don't want it too hard because that can irritate the foot, especially with something like a heel bruise.
Yeah.
So you usually want something that's about 55 to 75 durometer.
Yeah.
So again, depending on the problem, heel bruise, you want to go a bit softer.
Yeah.
Things like plantar fasciitis, you can go a bit firmer, that's fine. And then so you put your shell, you've cut your shell, you glue it,
Yeah.
then you pick your posting. Now the posting, this part here, usually you want 60 durometer or more.
Why?
because this is what holds the foot in this tipped position. So that means there's a lot of pressure on this little outside edge and a lot of pressure here, because you're using this little tiny piece of plastic to change all that stuff from a whole human body, which is, heavy. So then you cut your posting material, heat it up till it's floppy, stick it on, vacuum press it down.
On the other one, right?
On top of the shell, yeah.
So did you put glue on it or no?
Yep. It's got my contact cement. It's like a special, so I sort of mix my own glue. I use a material called Jet Set, which dries really fast. And then a little bit of the contact cement from Home Depot because it thickens it a bit.
Do you have to use UV lights and things like that or no?
Okay. Just time. Then we grind it with our sander. So that's where you take this chunk that kind of looks-ish like an orthotic, and then you use your grinder and you shape it, and then you put your correction in, and then you put it back upside down, and then you arch fill
Hey,
it.
wait a minute. Is this made for this?
No.
It looks almost perfect.
No. Look, see, there's a giant gap there.
Oh, see, I'm not a professional.
No. It's way too long,
You
too.
don't want me to make these, eh?
No, not yet. I'll teach you how then you can. But it does take a few years, so.
Oh, God.
Yeah, so then once that's done, you fill this, because if you fill this, then the arch is solid, and then when there's weight on it, it doesn't collapse. Is it this one? No, that one's.
What do you fill it with?
Usually a softer material. It just needs to be something so there isn't a gap. Because if there's a gap, when you put the pressure, it collapses. So you have no gap. The only time you don't fill it is if it's like a dress orthotic, like you're making it for a dress shoe, or like a ski boot, because the ski boots are so narrow, the boot itself actually holds the arch up, because they go, and they're like this wide.
They're so uncomfortable, ski boots.
Yes. They're meant to punish you for the thrill of going down the hill. Or if you're cross-country skiing, then just for the rush of the fitness. What is that? The endorphins.
Yeah. They're so heavy too. It's like, why does it have to be so heavy? Can they make it out of carbon fiber?
Some are.
Are you serious?
Yeah, really, really, really expensive ones.
You probably have to sell your house and then get one of those, right?
Yes, exactly, for the comfort. Yeah, and then you grind that off, and then you do what's called finishing, which takes the longest, which is where you do the edges. You take all the fuzzies, clean them up.
So when you put the layers up, right, I imagine this looks like a square, right? Does it look square? Or?
I cut them into rectangles.
Yeah, so
and
a
then,
rectangle.
Yeah, and then when I'm cutting them, they look
circular, like
sort of just really similar in shape to that, because we know the shape. So when you first start...
Right, because now you have these kind of things, right? This
Yeah.
kind of thing. How do you do all of that?
So when you first start, really poorly, and then as you practice. So like if I take a flat piece and I press it onto here, I can take it off and then be like, okay, so this marks the front. So yeah, I'd cut the front. And then I would just know, okay, cut the sides to be in the shape, because I've done it. I mean, I've built like tens of thousands of orthotics at this point. So
10,000?
Yeah, I did an estimate a few months ago.
By your hand, by yourself?
Yeah, more than that, a lot more than that. But yeah, I counted.
When do you sleep?
Well, we're fast now.
You know, the thing is, because this is almost like art, right?
Yeah.
It takes so much work to do paintings and things like that. This reminds me of all the crafts and things like that. But this is a professional craft.
Yeah,
right?
I know.
It saves lives and helps people.
But if you get someone that isn't good with their hands, they're not good at art, they're probably never going to be able to finish, like
It'd
do
be a
the
nightmare,
full orthotic.
right?
Yeah.
Basically, you know what this reminds me? This reminds me of sculpture.
Yeah.
You're sculpting
Orthotic shapes.
Yeah, this is amazing. Oh my God.
Yep. Yeah, and that's where, because there's a lot of people that try this, and that's probably one of the reasons a lot of people do use the bigger things, because they're the big labs, and they don't do it themselves because they can't.
They put on the feet, the person walks the other way, right?
Yeah, the other pedorthist, she's getting a lot better. She's been training for a couple of years, like hands-on building. We build Thursdays, Fridays. And then we also will build during the day when we're seeing patients. If someone cancels or we have a bit of time, we'll work in the lab. And she's just now starting to get to the point where she can do the finishing with supervision. And that's been, 2 years of lots of intensive hands-on, maybe 2.5 years actually now. So you know, the getting proficient is the really, really hard part.
This is something that you
And
cannot
knowing the
just slap
shapes.
on. So right, this takes a lot of work to.
No.
No.
Yeah, so the big things are when
Yeah.
you learn the conditions. So you learn the pathologies of things. So if someone says, okay, so my foot hurts first thing in the morning when I get out of bed, this area here, you have to know, okay, it's in this family of things. Check for one of these things. If they're like, oh, the pain's over here, you're like, okay, well, it could be one of these things. And then you do your assessment, which is I get the patient to lay down and then sort of, I've asked them all the questions about, you know, when their foot started hurting, what did they do? Did they injure it? Did it start out of the blue? Did they start picking up something like running? Did they start, I don't know, decide that they're going to do a marathon or what are those things?
Jogging.
Start CrossFit.
Oh, CrossFit.
Something like that.
CrossFit.
Yeah. And then now they're starting to deadlift or whatever. And then now their foot is really sore in this spot or their knees hurt or their ankle or whatever. And then I sort of figure out, okay, so it's going to be this area. So you poke around at the foot, you do the clinical test. So like if you think it might be an Achilles tendon tear, you would squeeze the calf and see if the foot moves. Because if it doesn't move when you squeeze the calf, you're like, oh, that is not good. And then you try not to alarm anyone. And then, you know, you look for just little things like holes or cuts. Like I had one patient who, she had been to 5 different people. She was wheelchair bound, so she wasn't weight bearing very often. She would transfer herself, which means she would go from her wheelchair to beds or whatever on her toe. So she would go down, twist, sit. And so I got her history, and she had had so much pain in her foot, which, considering she had no feeling in her foot, was really bad. Because if something starts to hurt that you can't feel most of the time, there's really your body being like, red alert, you know, pay attention, this is really bad, alarm signs. And I just picked up her foot and I looked where she would be transferring, and she had a hole in her toe, and I could see her bone.
You could see her bone.
Yeah, it was so infected that her toe was getting necrotic.
And nobody
Yeah.
noticed that.
Nobody had bothered looking at her foot because she's wheelchair bound, and they thought, well, she can't walk, she can't be walking on it. And then when I was like, okay, well, what do you do? And she's like, well, I do transfer. And I went, I bet you I know where the problem is.
Yeah.
So we sent her to wound care to the hospital for debridement and stuff, because we don't do cutting, we just do mechanical stuff. That's when they take all the dead tissue away with their little knives.
Oh, God.
Yeah. So we don't do cutting. We just do, hey, this is looking bad. You should go see like M&M Foot Care, she's great. She does like toenails and big calluses and all that kind of stuff. We can take pressure off the calluses and make it so that they come back more slowly, but she cuts them off. And then the hospital wound care clinic is for if someone's got a big hole in their foot and the tissue is dead, they cut out the dead stuff. Yeah, and wrap it and stuff. We don't do that. We do no cutting. We just look. Yeah. Anyway, so
then what happened with her? She came back and then you make her one of these?
no, we didn't do an orthotic for her. It was the sort of situation where just, I think she was doing it in slippers, and just once her foot was better, just a good shoe with nice cushioning that had a bit more support and a bit more of a sole, so when she twisted, it wasn't hard and there was no ridge. Because with a slipper, you're fit end to end. Your toe is probably here, and then there's that ridge of that slipper. So when she was twisting, her toe was sitting off, and it was just a pressure point digging into her toe. So that was just a shoe would fix that, a better shoe. So yeah, once her toe was better, just be a better shoe. Then I distracted myself about what we were talking about before. Right.
Well, finishing?
I don't know. Anyway, so.
No, you were talking, I think, the square things, and then you.
Oh no, assessments, right. What we're doing with assessments. So yeah, we do visual assessment, because a lot of times people won't realize that they have something going on in their foot, because you don't stare at your foot very often. And I've even had people that have just had, this spot of my foot has been hurting, and it turned out it was a sliver. It's just been there for a while that they couldn't see. Yeah, well, because if you're visually impaired, you're not going to see a sliver. So yeah, just things like that. So we do that visual assessment, and then we do like make sure the foot moves the way it's supposed to, and then poke it until we find where it hurts. And then sometimes we'll do some other tests, like, okay, so it hurts here if we like if someone has a hairline crack in their toe, like sort of in what's called the long bone. So they have a hairline crack here in the metatarsal long bone here. So if you poke, you're going to hit, say this is my hairline crack, this little tiny line.
Yeah.
So you're poking up, then you poke that spot, they hit the roof. Because hairline cracks really hurt when you put your finger on them. But then I'm poking here, that's not sore. A little bit sore here. That bone here is okay. Then the next test I would do is I would torsion that bone. So I would take the top and the bottom and put gentle pressure underneath.
Yeah.
Now, if it doesn't increase the pain, then you think, okay, they have a really, really bad bruise there. Something landed on the edge of that bone on their foot. But if I torsion that bone, what I'm doing is taking that hairline crack and just opening the edge of it a little bit. And if that increases the pain, then you're thinking, okay, that's probably a hairline crack. Same with big toe arthritis, right? If the big toe joint here hurts and I poke in this joint with my finger, I sort of poke there, and then that's sore when I hit inside the joint, then I move the joint and I go up, down, to the side, and it hurts in all three directions, they probably have pretty bad big toe arthritis. Or if it doesn't move, because it's, yeah, bones don't like moving. You know, and that's where what we do is the clinical exam. And the other thing is, because a lot of people say, well, do you know this if you don't have x-rays? And x-rays are really great to confirm a diagnosis.
No.
They don't tell you where the pain is. So we've had people who have had heel pain or pain in this part of their foot, and the x-rays will come back and show that they have arthritis in their big toe, which they do, but that's not bothering them. So that's where you never let the x-ray make the diagnosis. But, you know, if we know they have arthritis in that toe, we say, well, does that toe bother you?
Yeah.
And they go, no, it's my heel, and
Yeah.
every morning when I get up, my heel kills me. Then it's probably more something like plantar fasciitis. So they have the arthritis, but it's not their main concern right now. And then maybe once their heel's better, then they'll be worried about their toe, but that's what's their heel pain is what's stopping them from doing things. Or like I had one patient when I was still with Brian and I was learning how to assess knees.
Yeah.
And the x-ray came back and it said that they had medial knee compartments arthritis, so arthritis in this part of the knee, on the inside.
Yeah.
And then when we did the clinical assessment, so moving the knee around, stressing that arthritis, that didn't hurt at all. When we stressed the soft tissue,
Yeah.
that really hurt. So then we gave him a temporary wedge to see if changing his knee position, so stressing the arthritis and taking pressure off the soft tissue made him better or worse. Because if it makes him worse, we know the arthritis is the pain.
Yeah.
If we're taking pressure off that soft tissue and it makes him better, but stressing the arthritis, you know, then we know, okay, the soft tissue is causing that pain. So for that patient, he had horrible arthritis in the medial compartment of his knee, didn't bother him at all. He had strained the soft tissue that attaches that part there, because his knee was kind of like this, and he'd strained it. So he put the pressure on the arthritis, took it off that soft tissue, he felt better. And that's just where, you know, that clinical assessment is really, really important.
Yeah.
And then we get people walk, we have like a runway. So we open the office door and get them to walk to the far wall and back 5 or 6 times. And then we just do a visual, like you're looking for like a limp. So you're assessing how someone's walking. Are they heel striking, so hitting with their heel and rolling through and off their toes normally? Or are they taking a short step? They're stopping there, like avoiding that heel strike, hitting here because their knee hurts or their heel hurts or whatever. Are they doing what's called circumduction? So when you're walking and your hip is really sore,
Yeah.
instead of swinging your hip forward, you sort of act like it's almost like a peg leg and you swing it out because you're using your whole core to move your leg out instead of just going back and forth. So you're looking at all those things and seeing if, you know, it's their shoulder dropping, because if someone walks and they have a dropped shoulder and then one foot's rolling in, you're going, is there a leg length difference? Or I had one patient once that came in because she was really having a hard time with balance. She was practicing with her balance, but she would go halfway across the room and then almost fall over. And so I had her walk a few times and I said, like, have you hurt your left shoulder? And she was like, yeah, I did, like a year and a half ago or so. And then they surgically repaired it and it's just stopped hurting me. And then I went, okay, well, you're not swinging that arm. So she was holding this one stiff, and she'd swing this arm a lot, and she was overbalancing herself. It was nothing to do with her feet, they were fine, and her knees and stuff. It was, she was holding her one side stiff, she wasn't moving it at all, and so she'd started being active again, because she was, her shoulder was all better, she wasn't afraid of hurting it. She'd joined a walking group and started walking more, and just was swinging the one side and just getting herself to overbalance too much and almost fall. So I was like, hey, try swinging that arm now. And so she went to a physiotherapist, and they worked with getting the movement back in that arm. And that was good. Yeah. So you see stuff like that too. And that's where, the hands-on assessment and the hands-on visual things are really, really helpful. Because sometimes it is, stuff, or, you'll notice something and ask more questions and suggest stuff. There's a thing called the tib anterior. So when you walk, this toe comes up when you walk. And so you sort of heel strike, and then it decelerates, so it slows down before it hits the ground, and then it pulls this toe back up. So tib anterior for walking is really helpful. If your tib anterior, so this doesn't work, that tendon doesn't work, you trip because your toe doesn't come up. And when you're taking a step, your foot slaps on the ground. So if you've ever heard someone walking and they kind of sound like, and then you see their foot's dropping, it's called drop foot. And then when they go to roll off their toes, instead of it coming up, they have to just lift their leg because their feet kind of do that. And that's can happen from different things, often strokes, they're the big ones. So sometimes you'll see someone, and without any idea that it happened, they'll say, yeah, just, I was coming out of my house a couple months ago or a few weeks ago, and then tripped and fell down my stairs. You're like, well, why did you trip? Did you lose balance? Did you have pain? What was the reason? And they're like, no, but my foot doesn't work right anymore. And you're going, have you been checked for a stroke? Because for tib anterior to fail completely, usually it's something like a stroke, Parkinson's disease, there's something that causes that to stop. And so we'll sort of suggest that maybe they mention it to their family doctor, because that's the other thing is we do half-hour appointments, so 30 minutes, and we have time to spend with the patient. And often with family doctors and the way it's scheduled, they don't have that
5
time.
minutes maximum, right?
Yeah, so the patient will go there for their chief complaint, which is I hurt my knee or my hip or whatever. And then when we see them, it'll be for that, and then we'll notice something else, and we'll be able to follow up on that. So that patient that had that drop foot, and it started out of the blue, he was actually there for seeing us for a completely different reason. I think it was his toes were on the other foot causing problems, something like that, and it was unrelated. And we went, have you brought that to the attention of your doctor? And he hadn't, because he didn't realize it was a big deal. He was just like, oh, this is weird. And we're like, yeah, but it shouldn't be doing that. So so just little things that we can do during that assessment. And the other interesting thing with orthotics and drop foot in cases of, and this is just a specific interesting thing, because when you do this long enough, you're like, oh, that's really interesting. So what they found with people with Parkinson's disease, when you add an orthotic, tib anterior, which is the one that stops working if you have Parkinson's, starts firing again. So that muscle starts, that part of the foot starts working again. The muscles start working, the tendons start working, that weren't working at all before, when you add an orthotic with a really high arch and a little bit of texture to it. The downside is it makes the balance way worse for the first couple weeks, because the body hadn't been using that area, and now it's like, oh, we can use it again, we remember it exists. And then it's like, oh yeah, no, but I don't work yet. So it improves the function, which is just sort of one of those interesting, the person that was studying something and discovered that was not looking for that at all. They were studying something totally different, and they just noticed when they did brain scans on these people, that part of the brain was firing those muscles, which they hadn't been for
Did it fix
ages.
it after a while, or?
When they were wearing the orthotics, yeah.
But then they didn't wear it, was it the same, right?
Yeah, their balance was still bad. And that's the other thing is post-stroke recovery, anything where balance is an issue. when you add something like an orthotic, so post-stroke, you're putting more pressure on more parts of the foot. It helps people start walking faster if they have an orthotic and regain function. Things like with Parkinson's, or even after chemotherapy when the feeling in the foot isn't as good, if you touch more of the foot, the odds of you getting that one nerve that's actually still doing its job are higher. So that's just kind of a really interesting thing about that. It's an aside with the chemo. And we even have a material that, what is called Nuboso now, which is,
Nuboso.
yeah, it's really neat.
Oh.
It's pokey. It's like little tiny spikes all over it.
Yeah. It's like pressure points almost, right? It's like
Yeah.
acupuncture for the foot. Is that
Yeah, and the idea is that if people and we're sort of, so far early results have been positive if someone has had something like chemo, so they're not diabetic, they haven't had ulcers, anything like that, but their feeling to their foot isn't that good from things like chemo, car accident, that kind of stuff. The little nubbles all over it improve the feedback from their foot, so they're able to do more,
Yeah.
and their foot, because it irritates the heck out of the bottom of it,
Yeah.
their foot's more alive. It's
Yeah.
going, hey, I exist, which is, always a positive, because it really helps you find the ground if you
Yeah.
can know where it is.
Would it fix the problem after a while? Be the
Yeah,
pressure
so
point?
hopefully, because it's still a new material and it's
Yeah.
still early days. So usually with things like chemotherapy, eventually the sensation in most cases does return. But it's very dry in here. Anyways, but
Sometimes it gets cold too.
yeah, but it's just like we just don't know yet whether, we don't know if the Nuboso is going to make that sensation return faster,
Yeah.
or if it's just time that's doing
Yeah.
it. But what we have been finding is that it improves the confidence
Yeah.
and the sensation. So people, instead of feeling like I'm never going to have feeling in my feet,
Yeah.
I just can't, they feel like I can do a little bit more walking today. So it's giving that confidence and that hope. And because eventually, yeah, usually the sensation
Comes back, right?
slowly
Yeah.
returns. In most people, you get the lucky odd person that never happens, but in most people it gradually returns to some degree. It's not always where it was before, but
Yeah.
to some degree it does. But it's sort of hard to stay, if
Yeah.
you're an active person, it's hard to stay positive and upbeat if you feel like you can't do anything. So with the Nuboso, really bumpily top surfaces, like we're having the people be like, yeah, essentially the early feedback has been, it's been giving people hope and increasing their ability to be more active. So they're saying, well, like I had one patient today that was saying, I don't know if it's making a huge difference, but I can do more walking wearing them than when I'm not.
Yeah.
And I feel more hopeful about it. So I'm like, okay, well, I mean, I'll take that because
I mean, at least it's making a difference, right?
yeah, exactly. And I mean, when you've undergone traumatic stuff like cancer, honestly, any little bit of hope is really helpful. Because it's just hard.
What are some of your success stories?
Usually it's more complex ones. So I have to be careful with details because of confidentiality. But I've had cases where like people that are, were sort of their last hope before amputations. Like that's the big one, where they've done everything, they've lost chunks of their other foot, and then if you can't do anything, it's gone. And we've had some cases where we've actually been able to save the foot. That's always hit or miss because sometimes you just can't. Like we've had stuff where, because a big thing of what we do is like lots of quality of life stuff. Because, if your foot's hurting, you're not going to die of it. But it does improve your quality of life a lot if it's exhausting to be in pain. So we've had things like where we've had one of my patients, and he'd be okay with me sharing that, he wasn't able to walk his dogs anymore because his feet just hurt so much all the time. Like he just couldn't. And him and his wife would walk every single day together. And then he had another neighbor that had heart problems, and he would walk with her just to get her out and being active and stuff. And he just couldn't. His feet hurt so much, he just couldn't do it anymore. So we did some orthotics for him, and yeah, he was able to walk with his wife again. And ran into him in the dog park, and he was like, "Oh, this is so great! I can do this again." And yeah, so that was nice, and he was very pleased with it. And it's just the sort of thing where, again, it's not a life or death situation, but for him, for quality of life, it was huge. So yeah, we get lots of those. Yeah.
You're like a genius in your field.
Yeah,
Like
we like to think of things.
Oh, serious. You're so knowledgeable of this stuff. Like, we rarely see somebody with that level of like expertise and things like that. Like, it all comes out, right? The way you're concentrated, the way you talk about it, like, ins and out of this thing.
Yes, well, and we go to conferences. That's the other thing is for podorthists, the continuing education requirements are a lot more than a lot of professions. So you have to go to conferences like every other year, and it's interesting. When we were at one of the conferences, one of the people stood up and was like, "I don't know why we're putting so much emphasis on diabetic feet. You never see them." Because in big cities, because he was from Toronto, they probably wouldn't send it to just a random person. But here, because of where we're located and us being, we customize, we're the only ones that do sort of soft things like this, you see everything. Like, you see the crazy motor vehicle accidents, and that was another success story. I had a patient that, and she'd also probably be okay with me sharing her story, but when she came in, she had had a motor vehicle accident a couple years before, and her toes on one foot were stuck on this position. It was the one that she'd had on the brake. And they would be like this, and her foot was swollen, and she couldn't get them down, and she was almost in tears going, "I can't even walk. Like, I can't wear shoes. I can't, like, what do I do?" Because you have to wear boots here in the winter. So we assessed some stuff, and I realized what's called the plantar plate, which does this with the toes. I realized it was disrupted, so it wasn't working right. So we did an orthotic to force her toes down, special shoes that had a roll on them, little exercises and stuff like that. And I mean, now her foot looks like a foot again. She can get in shoes, she can wear sandals, she can walk, she can hike, she can work, and all that kind of stuff. And so we see everything from like motor vehicle accidents and things like really interesting industrial accidents and just your standard running injury. Because most places in big cities, they see a million running injuries and not much else. And then we see like...
So what are some of the running injuries?
Usually plantar fasciitis. That's the biggest one.
Oh, because what happens there?
So your arch, it's a repetitive microtrauma injury. So
when you run?
Yeah. So your fascia, your arch, goes from your heel to the ball of your foot. When you think about running, your heel striking or forefoot running, doesn't really, either one of them. And then you're sort of pivoting onto your toes and pushing off with a lot of force to propel yourself. So that movement over and over, whenever you go heel to toe, your arch kind of slingshots. So it pulls tight and sort of shoots you into the next step. And a lot of people, when they first start running and stuff, go from like 0 to 90. Like, they'll be like, "I ran for 5 minutes, it was great, now I'm going to do 10. You've just doubled your running time. And then they get plantar fasciitis, which is an overuse injury. So their fascia, their arch goes, "You slingshotted me too fast with too much force too many times in a row. I'm going to rebel." And then they get little micro tears here at their heel, so here. And then a little bit of swelling. And then sometimes they get some bony buildup because the body tries to enforce it. So so plantar fasciitis is the most common running injury. And then, with that, it's usually you do an orthotic in and out of the house all the time to splint that arch. Shoes in and out of the house with the orthotic, and then gentle stretches. And then you sort of baby it better. And then when you start running again, you remember that between 5 and 10, there's other minutes. So there's like 5 minutes, then there's 6 minutes, then there's 7 minutes, and 8 minutes, 9 minutes, 10 minutes. Because if you go from 5 minutes to 10 minutes, you've just doubled your time. If you run for an hour and a half, adding 5 minutes, adding 10 minutes, that doesn't matter. But if you're just starting running and you can do 5 minutes, if you add 10, you're now doing double. And then if you do 15, like, that's another third. But people always forget that your body has a memory of a goldfish when it comes to activity. You haven't done it in 6 months, your body's like, "No, we have never done this in our lives. We've just never done it."
So I guess running is not safe, like they say, right?
Well, it's okay if you build up properly and if you run, say, in summer.
Yeah.
In the winter, you're either switching to treadmill or in the pool.
Yeah.
So if you keep running all year, but you just switch where
Yeah.
you're running. And then when you're building up, you build up slowly. We get a lot of people hurt from what we call the terrible twos, which are too much, too soon, too fast, too often. So you're trying to learn to run. You've never run before. So now you're running every single day. That's too often. And you're running for 5 minutes, that's feeling good, then you're doubling your time. Or you start running with a running group or a friend that is a runner, and you're increasing, your distance, you're adding distance, hills, speed all at the same time, and then you get hurt. So overuse is the really common thing. Whereas if that same person had just built up more slowly and listened to their body being like, okay, I'm doing too much today, we're going to be nicer, and then taking a rest day, because the other thing is a lot of people think do the same thing 7 days a week. No, you need at least one couch potato day. Your body likes that. So that's just a really common, probably one of the most common running injuries. The other one is the hairline cracks.
From running.
Yeah. So if you run a lot and you have a high arched foot, that's when you add an orthotic. If you run and have a high arched foot, you've got something here. So when you're running, it's sort of rolling instead of going slam, 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 and then getting the hairline cracks. Because if your foot's high, it does not. If you have that really high defined arch, it doesn't absorb shock very well. So those little bones get a ton of pressure.
What are some of the most injury sports when it comes to foot?
Right now, pickleball.
Are you serious?
Yeah, because
Pickleball. Why? I thought it was like
it's a terrible situation.
You were talking about it like it's this glorious. I have to go see it. I'm gonna research pickleball.
Pickleball, yeah.
Pickleball. I'm gonna research.
But
that.
it's the same thing. So we have a lot of patients that retire, and then you go from working all day, every day, and then now you don't have that. So they fill it with a sport, and pickleball has the social aspect. It's fun. Getting into it is not very expensive, so it doesn't have like with skiing, you need to buy the skis and the boots and all that kind of stuff. With pickleball, you need the paddle and a ball and a court, which there's courts everywhere. So it doesn't have a high barrier to entrance, and a lot of the groups, there's always someone playing. So you have that, it's just such a good community. And then, so we have people that will start going from almost never doing much, like maybe once a week doing physical activity, or not really because they had a very demanding job, to now playing this quick, rapid change of direction, start and stop, short sprint sports 3 times a day every single day, like 7 days a week, 3 times a day, or 5 times a day, 3 times, or 5 days a week, 3 times a day, and then tournaments and all that kind of stuff. So they get overuse injuries. So yeah, we see mostly it's pickleball related injuries for sports. Now you thought it was going to be something different, right?
I thought it was going to be rugby or some MMA or something like that, right?
No.
So you're very passionate about this, right? I mean, you're doing it.
Well, it's always different, right?
Why are you so passionate about this? Like, what happened that you wanted to go into this field? Like, it has to be like this deep reason, or because you're so good at it, like
I mean, it was just like an interesting thing. Like I said, when I was working at Timberline and I was seeing diabetic patients with all these issues, and there was just no one helping them, and I was like, I bet you I can do that. And when you're seeing something like that, because I don't like jobs where you do the same thing every day.
Yeah, it gets boring.
Yeah, and with this, I mean, every
time
patient is
right?
different, yeah, and every injury is different, and every use case is different, because and different barriers. So you've got the people where they all have different stories about what happened, and you get to talk to them and hear about what they do and where they go and all that kind of stuff. Like, I've had patients that are getting orthotics so they can go travel around the world, and they want to be better before they go on this big walking tour, and stuff like that. So, you get interesting stuff like that. And then the things that I really enjoy, like the diabetic ulcers, the Charcot-Marie tooth disease, and these things that most other places are like, ugh. The big open wounds on the foot that are infected, all that kind of stuff. I find that fascinating. And in part because no two cases with that are the same. Everyone that has, it's like slightly different. And what worked for this person might not work for this person, so you have to be creative and think of a new idea. And so you got to be creative. You make something with your hands, but then you also do the brain work where you turn your brain into like a dictionary where people describe their problems, and then your brain flicks through and goes, okay, section here for this, this, or this. Okay, we'll check for these, we'll do these relevant tests. So you do that brain work, writing the letter with the medical terminology and stuff for the family doctor, because we update the doctor with what we've seen. And then you do the hands-on, and then you produce something. And then, so you have that physical of production. And then it goes under the person's foot, and then they feel better, and, or they don't, there's a pressure point, and then you change it. And so it sort of gives that extra, dimension of, because a lot of jobs that do the brain work, you don't have the physical production side, you don't have the creativity side, or you have the creativity side, but you don't have the other side. Yeah. And this one kind of has both.
So it's wholesome. You feel good because you make a difference also.
Yeah, and if you want to take a bit of time off, or you make a mistake, nobody dies most of the time, good. Which is nice.
That's a good thing.
Because if you're a surgeon, you can't have an off day.
How did you start the business?
So I was working with Brian for ages. So when I started working with him, like a long time ago, he was going to be retiring soon. Yeah. So I first met him like 22 years ago, and he was going to be retiring soon. Yeah. We wanted someone else to take over. So then I finished my first part of my schooling, and then I did some learning with him and went, yeah, this is definitely what I want to do. And then I worked under him for a long time. And then, he retired, and I took over his practice and renamed it and stuff.
Was it difficult, or was there clients already?
No, there was already clients. So I'd been working with him for about 8 years, maybe a bit longer. So longer building, but seeing patients for 8 years. And then, so I already had my own patients and my own, like when Dr. Bell was alive, before he passed away, he used to refer his diabetic patients to me. He was a podiatrist in town, but he used to refer his diabetic patients to me because of like he used to say, well, you can think outside the box. So what do you think you can build for this person? Because I'd think of ways to help that might work. So I had, referrals from him, so old patients that had come from there, and then some of Brian's old patients, and then my own patients, because I'd been practicing for a while. And then we also are we have a policy of if they don't need them, we won't build them. Yeah. So we don't recommend orthotics for everyone that walks in the door. So sometimes we're like, you know what, get this off the shelf insole, get these shoes, do these stretches, it should fix you. And then if it doesn't, then we'll do orthotics. Or, we have some people that are just, literally they're just wearing the wrong shoes. Yeah. Like the wrong size, the wrong fit, whatever, the wrong shape. And we're like, try this instead. And we get referrals from the family doctor for that reason, because it's not an automatic, they're going to need orthotics. Yeah. Like if we really don't think they'll be beneficial, we go, no.
Not everybody does that, eh? Some people, they're like,
everyone needs
another one, right?
Everyone needs 2 sets, one for their left hand and one for their right hand, and one for their feet, and then probably just extras.
You're not that type of a person. That is amazing.
Yeah, and the other thing is we always start with 1 set because, orthotics don't work for everyone either. Yeah. So we've had some patients that they need them. It's something like plantar fasciitis. Now, 75% of the time, you add the orthotic, you do the gentle stretches, you be consistent with wearing the shoes in and out of the house, they're a good shoe, the person gets better. But then that leaves that 25% that don't. Yeah. And then, so they've tried the orthotic route, and then now they've got to try aggressive physiotherapy to re-injure the area, because it's changed in nature. So, we always say start with 1 set, because, you can move, if you have 1 pair, you can move it from shoe to shoe. But you don't want to buy 2 pairs and then not have them work. Yeah. So it makes sense to start with 1, and then if you really like them, then you can get another one later. Also, we if we don't break the cast, because sometimes we break them when we're building, because the suction machine because every layer we have to suction on, and they're all, they're different, all those different layers. So sometimes the suction machine, after layer 3 or so, eats the cast. It just, all the toes pop off and it breaks in half. So then we throw it away. But if it doesn't get thrown away, then the people get to keep their foot in plaster, which is
That's crazy.
bonus gift.
Right, it's a gift.
Yeah, most of the time they don't want them, but you know, there's a craft that we suggest where you dry it like this, where it's all light, and you clean it off like this, and then you take food coloring and you drop it on, and then it sucks the food coloring up, looks tie-dyed, then it goes in the garden until the plaster melts. Yeah.
Listen, what are some, so shoes are very important, right? So what are some of the good shoes that people should be considering?
So with every brand, there's everything from fun to that is ugly, looks like my grandpa would wear it.
Yeah.
Most of the time, the good shoes fall into that's really ugly.
Yeah.
So if you see a shoe that's cute, it's probably not good. There are some exceptions, but most of the time, the uglier the shoe, the better. And what you look for is like a firm heel counter. So right where, I'll show you a boot. I'll take a boot. I take a shoe, I can show you. Works
Are
easier.
you taking your shoes off?
It's my
Look
boot.
at-
So you
Oh,
want it
this
firm
is
back
nice.
here.
This is not the,
Hey, it's my boot.
this is nice. Oh, look at you. This is, oh wow, look at the colors.
I know, he's
Oh
old
my
though.
God. Oh, I like you know, I do art and paintings, right? So I love colors. This is such a nice balance, right?
Yeah.
See the shades and stuff. Like, I'm
Well, and
gonna
it
go
goes with
crazy.
almost
I shouldn't say
everything.
anything about colors. I'm gonna go on forever.
So
Okay.
it's firm back here. So
Yeah.
this is the part that actually holds your foot
Yeah.
on top of the shoe.
Yeah.
So if you can squish it like this down here,
Yeah, it's not good.
it's a risk of an ankle sprain or an ankle fracture. Because if you hit an uneven surface
Yeah.
and you sort of twist your foot a little bit,
Yeah.
before you even fall off, say, the sidewalk, you've fallen off that platform of the shoe. So you want it firm back here.
Okay.
Next thing, you shouldn't be able to wring it out like a wet towel. So if you can take this and you can really, really twist it, see this one's getting a little twisty because
Yeah.
this is a very old shoe and I can actually hear the shank in there crunching, so it's broken. Anyways, so if you can take this and it should twist if you're twisting it kind of about that much. So this one's a little too twisty.
Okay.
And then the final thing is if it bends, it should bend only where the big toe bends. So it shouldn't bend back here or here. And if it doesn't bend like a hiking boot, like a stiff hiking boot, it's not going to bend. The toe should sit up like this, and it should roll like a rocking chair. So it should kind of rock into the next step. Now we're going to assess your shoe
You sure?
and tell you if it's a good shoe or not.
Oh. There we go. You want to
Okay.
touch it? You sure?
Yeah, that's fine. I mean, I touch feet all day, right?
Yeah.
Yours don't have any oozy wounds, so it's good. So first thing,
I have 3 pairs of these, so
yeah,
it's,
you don't want to wear a rock in your shoe as a whole. I think these ones are should be filed what we call filed under
Yeah.
G,
yeah,
which is garbage.
yeah,
So if we look at this shoe,
yeah.
oh no, that
Oh,
heel
God.
counter
Oh
is
my
not
God.
there.
So, you know how many pairs I have? Like because I only very specific shoes, right?
Well,
this
these
is-
ones are old.
This is only maybe I bought it.
It's from Aldo.
I know.
When did Aldo disappear?
No, they're still around. I still buy from them. We should not say the name of the brand. Oh my God.
Okay, so the bend, the flex point where it bends here, that's good. The downside is it should not do that. If your foot bends in this spot,
Yeah.
you've broken it. It needs to be repaired because that would be like it bending
Yeah.
up through here.
Yeah.
You do that if you shattered your foot,
Yeah.
had like a big industrial weight, just
Yeah.
then you could bend it like that.
So what kind of shoes should I buy?
So then, wait,
I
one more
literally
thing.
have.
Bring out like a wet towel. Now, when you look at the sole,
Yeah. See, I have footy shoes, right? Everything gets sanded down.
yeah, this is a normal wear for heel strike. You put a lot of pressure on the ball of your foot.
Yeah.
You can,
Because it got dislocated, right? So.
sure.
No, I'm serious. No,
That's-
this one. This
That's the
one.
excuse, though. But no,
We gotta pause, your mic just died.
The mics died.
Oh,
Both of the
no.
mics.
but I was making fun of his shoes.
It was good. I looked at them.
It's still on.
Oh,
Oh, is it on?
are we just talking too quiet?
1, 2, 3, 4.
Lost it for a second.
Oh, okay. So this is your wear pattern.
Okay.
And this is actually not a bad one. It just shows that you put a lot of pressure on your toes.
Okay.
Some people are really stompy on their heels,
Yeah.
some on their
They
toes.
can always take the other one off.
This area here, you can tell that this shoe has a grid. So I don't love the grid pattern for shoes for a couple of reasons. One, because see, you've got more rocks in here. You actually have, do you hear the rocks when you shake it?
So this one is the one that is dislocated. I have this angle on it.
Yeah.
That's
Now,
why every 6 months I have to throw the shoes out.
it's okay to have that angle because if you don't, that's remember I was talking about tib anterior. If you don't have a bit of an angle there, if you're not heel striking here, that means you're doing that or catching your toe and tripping. So that's okay. Some people wear it faster. So you can see with this one,
It wasn't like this before.
yeah, it's worn down compared to this side.
Yeah.
So that would also be your dominant foot. It's the one you pick on more, you use more. And this is a pretty normal wear pattern. You pronate a little bit here, late stage pronation. So you roll in before you go off your toes. And that's probably the difference there with, compared to this side,
Yeah.
with your toe injury, or your
No,
toe
the whole
injury,
thing
your
came out.
ankle
I
injury,
put
yeah.
it back in place. And I went to the hospital. Then it took me 7 months of recovery, actually.
Look at that. You see?
I know, it's this, I'm moving, so I'm throwing all this out. So, but I have like
Okay.
literally 3 pairs of this one.
Yeah, so, and the other thing is now,
I don't know what
if
to
you're
do
not
now.
doing a lot of walking in them, slip-ons are okay.
No.
But if you do a lot of walking, they're not great. And the reason is because if you're wearing something like this and you're going for a big, long walk,
No.
to keep this on so you don't kick it,
Yeah.
you grip with your toes.
So these are not a good type of a shoe, like, because
They're okay for sitting, not for lots of walking. You'd be better with a lace-up that has, again, you want it firm back here,
Yeah.
can't wring it out like a wet
Yeah.
towel, only bends where the big toe bends.
Well, for business, this is okay, right? I usually wear shoes like this for business. Then I have sport shoes and things like
For
that.
sitting business,
For sitting, I shouldn't even be walking in this.
not a lot of walking.
Are you
no.
serious?
They're
What
not-
do you
they're
think?
not
I wish I.
supportive for
Oh
that.
my God, you know how many pairs of one of these? Well, because I tell you, what my problem is after 6 months,
Mm-hmm.
because of that thing, you see that side, I have to throw them out. So I have 3 pairs of these. I will have
Here's
10,
your rock.
10 different pairs. Like, there's so many. my-
Yeah, if you go to a shoemaker,
Yeah.
like Jerry at Stevenson's
Yeah.
Shoe Repair
Oh, he
in
was
Prince
here.
George.
Have you seen his thing?
Yeah, he's been here. Now, he's actually, that business has been in town forever. It was, his dad opened it.
Yeah.
Jerry is in his mid to late 80s, and he's the son. Steve was his dad. Steve opened the business. It's been in Prince George forever.
Steve, you know, he said that we have him here. We had him here on the show.
Yeah.
So Steve is his dad.
Yeah.
He didn't say Steve, but he said Steve was his. He worked for Steve. He said
Yeah, he did. He worked for Steve. Steve
Yeah.
was his dad. Steve passed away a few years ago now.
Steve was his actual dad.
It was actually his dad. So it's Steve and son, and Jerry is the son. So, but Jerry can actually put a little
Yeah.
plate on the shoe
Yeah.
that makes it so that it stops wearing out as fast in that spot, or once it's worn, it gives it a bit more light.
No, I'm gonna throw it because every couple of months I have to throw my shoes out,
Yeah.
right?
So
That's
instead
why-
of throwing them out,
Yeah.
get more expensive shoes
Yeah.
and get a shoemaker to put a little graphite plate there.
Oh, how many expensive shoes? What are we talking about here?
Well, what do you think an expensive shoe is?
Oh, this was like $130 because it's leather and all that stuff.
Yeah, so for a dress shoe,
Oh.
a good dress shoe, you're probably looking 170 to 200.
200.
Yeah, around that price range. For a running shoe,
Yeah.
I mean, always check for those features.
Yeah.
But shoes are something that most of the time, aside from going for like fun name brands like Flubog and stuff, which are, they're fun shoes. But like most of the time for
Yeah.
shoes, it's
Yeah.
worth it to spend the money.
Yeah.
So it's worth it to spend the $150 to
Yeah.
$250.
But then I can only wear it for a couple of months and I'll throw it out. That's the only problem.
But if you get the better ones,
Yeah.
the shoemaker can add that little graphite plate and
But
then
there's
make
no
it
shoemaker.
awesome.
Not every city has shoemakers. So what do I
So
do? Is there a way that I can do
Prince
something?
George does,
Yeah.
Quesnel does,
Yeah.
Fort Nelson does, Vancouver has
Yeah.
some. So there's not a lot, but there's still some. Or you can take up shoemaking because there is a need.
I don't have time.
That's so we do some alterations
yeah,
where we work, but
yeah.
that's the big issue is we don't have time to do that.
Is there a brand of shoe that I don't have to worry that I can just get it and just
For that
so I don't have
sort
to
of
do all this
wear,
stuff? Yeah.
so a bit more firmness, but every brand has the that's a bad
Yeah.
shoe and that's a good shoe.
And there's some shoes are just flat on there. You know which I'm talking about. This I have to always buy with a thick grip, right?
Yeah.
Because if I don't have the thick grip, I have to throw it out in 2 months.
So I would look at
Yeah.
the brand Dunham.
Yeah.
They
Then I-
have some shoes with what's called a roll bar,
Yeah.
which is like a little thing that goes through the heel and
Yeah.
holds the heel a bit more stable.
Yeah.
So it's going to slow that wear. But Dunham makes,
Yeah.
they were owned by New Balance initially, and they were so New Balance's running shoes,
Yeah.
and they were the dress shoe version. And since then, they've sold to Rockport, so now Rockport owns Dunham, but they've kept a lot of that sort of running shoe
Yeah.
technology.
So it's Rockport now, right?
Yeah, it's
Okay, I'll
Rockport,
look into it.
but better than a lot of the, Dunham specifically has different widths, and they have a
Yeah,
bit more, they have roll bars on
Yeah.
some, and they just have a bit more cushioning.
Yeah.
So, yeah.
Maybe it's gonna say I'll buy shoes in bulk. I'm serious. I'm not joking. Like I literally
Yeah, if you
have
find one that works, always get more,
Yeah.
but lace up, not slip.
lace up. I'm not for,
Yeah.
okay, maybe for others, but for business, I cannot wear lace up. People don't take me seriously.
Hey, you can
Right?
get dressy lace shoes that are pretty. Also, where are you moving to?
Kelowna.
It's fine there. You could go to Vancouver, you could wear yoga clothes and runners and everyone would take it.
I
It'd be
can't,
fine.
obviously, I'd like to be dressed up.
See, that's what it is. But you know, that's the other thing to remember is like if your feet hurt,
Yeah.
you're just grumpy and miserable and then no one wants to interact with you. But if you've got happy feet, then
Yeah.
you're happy
Yeah.
and then you're cheerful. And if your friends are like, hey, let's go do this thing,
Yeah.
you'll be like, yes, I will do
Yeah.
this thing with you. Instead of being like, oh, I don't know if I want to. See, so it's
No,
more
I have
fun.
sports shoes. I do sports and things like that. But when I'm business, I have to, you know what I'm saying, right?
Yeah,
You walk
but
in the
that's,
room. You have
again-
to own the room, or the room will own you.
The Dunham
I-
shoes, they have ones that have, they look like the,
This turned to a therapy session.
I know, right? It always does. If you go somewhere and you
I
don't
should have came with socks today.
I would have had critiques for those too. Let's see. What are
Oh,
you
for
wearing?
God's
Cotton
sake.
socks? Oh, see, merino wool. High merino wool content is more moisture wicking, so
Wool?
your feet
Wool is
stay
better?
dry. Yeah, merino wool
Merino-
with no cotton.
what
And
is
cotton also gets hard. The fibers get hard. So if someone gets blisters a lot,
Yeah.
merino wool is better. Oh, and if you get blisters a lot doing sports,
Yeah.
you know how you can get those women's nylons
Yeah.
that from like
That's
Save
all-
On?
Yeah.
Yeah, you wear those under your sock, won't get a blister. They're great.
Just under my sock, right?
Yeah.
Okay.
When
just
you're
one-
doing like skiing or hiking or backpacking, if you go on a big long backpacking trip, then it's so much better than moleskin. We can even, if you want, we can look at his shoes.
Jeff.
Do you want us to make fun of your shoes?
I'm kind of curious.
Oh my
Guess we
God.
have to now.
Yeah.
We have no choice.
Called you out.
These are your winter boots.
Yes, they're, what brand are they?
She's thinking, oh,
Baffins. So for a winter boot, I don't know how your foot's not cooking in these right now though.
Yeah, kind of.
So this is not super new. Hey, you've had these for a few seasons?
Few seasons,
Yeah. See, and this one still, even though it's a few years old, firm back here.
yeah.
It's starting to get a bit wiggly this way, but it's
Yeah.
still firmer than yours. Bends where the big toe bends.
Mine is a couple of months old, seriously.
Yeah, well, it was, what's a good way to say this? Nice way to say this.
Well, it's okay, I'm not emotional.
It
You can say
was,
whatever, it's horrible, you can say whatever you want. I don't take...
Yeah, it was, you were beat before you even started the race with those shoes. Yes. And just, you know, checking the quality,
Yeah.
because every brand, again,
Yeah.
has everything from
Yeah.
that shoe is just for
Yeah.
looks to that shoe is actually a good shoe.
But this is for business, I have to look good, right?
Yes,
Right?
and it's fine if you're sitting. But if you do walking,
No, I don't go, you know, if I'm walking in the shoes, yeah.
so see, it's a better shoe. So see, he wears better shoes. Still not great on the sock.
Jeff, what is your foot size?
Steal his shoes. Yeah, there
Don't
you
you have to go to the bathroom? Take it.
So we're still not, now if you wear those with a nice wool sock, your feet stay dry and they won't get as cold. Because you know how sometimes your foot gets
Yeah.
cold in the winter?
Yeah.
And it's just like
Yeah.
ice cold, and then you're like, it just can't warm up. And usually in that case, if you pull off your sock, your foot warms up. And the reason is because your foot has absorbed, feet sweat a lot, and there's so many sweat glands in the feet. And if you wear a cotton sock, cotton works really well for like clothing like this because you sweat into it. It absorbs the sweat.
Yeah.
Then wind comes past,
Yeah.
dries the sweat, it cools you.
Yeah.
In your feet, in your shoes, there's no wind. So you're sweating, this cotton's absorbing all the sweat and it gets soggy.
Yeah.
And if you're out in the cold, then that sort of freezes a bit and it gets like ice cold water,
Yeah.
sweat water on your feet, keeping your
Yeah.
feet cold. So then if you pull it off, your foot warms up.
Yeah.
And if you wear a high merino wool content, merino wool pulls the moisture from your skin
Yeah.
so that you don't have a wet foot, don't have a soggy foot. And I was hiking once and I stepped in a puddle with my boots. Well, it didn't look like a puddle. It looked like snow over something. And then halfway through, it wasn't snow. It wasn't ice. It was just water with
Yeah.
pretending. And so I stepped in water up to my knee. And I thought, oh, my foot's going to be freezing by the time I get home. And no, it was fine. My sock, my foot was totally dry. My sock
wow.
I had to wring out,
Yeah.
dump the water out of my boot, but my foot was dry. It wasn't cold. It was fine.
Oh, I've got to look into the socks,
Yeah,
right?
right.
All this knowledge
Socks
we're getting
and
today.
shoes. Yes, but shoes are, because a lot of people will spend a lot of money on like a purse or a pair of jeans
Yeah.
or a shirt or whatever.
I'm a shoe guy. I like shoes. I really like
Well,
shoes.
then spend the money on them.
Well,
But again,
see,
get shoes that look like your grandpa would wear them.
There's no
or
way.
your dad.
I'd rather chop my foot off.
But see, that's the thing, right? And then it makes it so you can do stuff
Yep.
more for longer.
Yeah.
Because, you know. And then the ugly shoes are for when you're being active, when you're doing
Yeah.
lots of walking, and then you can have the pretty shoes for if
Yeah.
you're sitting.
Yeah.
So like our office now, we do a lot more standing because we've got the lab on site. So the lab is actually in the office. And we have like a standing desk because it feels so much better for backs. And we're up and down a lot.
Yeah.
So I wear running shoes,
Yeah.
which do not match my outfits at all, but my feet are happy.
Yeah.
Also, I have to set an example. My other office, we did a lot more sitting because the lab wasn't there. So if someone didn't show up, you'd just sit there and
Yeah.
play on the computer. And the desks were sitting desks, there was no standing. So a lot more back pain, but I could wear cute shoes
Yeah.
because I was sitting more. But now, with all the standing, usually I wear runners. And right now I have a lace-up boot with a zipper. And see, it's not an ugly boot.
Yeah. It's a nice boot.
And see, and so there are things.
What's your foot size?
Not the same as yours, unfortunately.
That's bad.
You're what, men's 11 or 12?
10.
10. See, the pointy toes, the square toes, a little throwing that off. But yeah,
I like my toes to breathe, right? Some shoes are like this, right? It's so
yeah.
painful.
No, and that actually causes, the really pointy toes causes a lot of problems and sometimes deformities. So like I saw one patient, I will always remember them. It was when I was at Timberline before I was even doing this. And she'd come from one of the foot specialists and her foot was, she had worn heels, pizza-toed heels for so long that the bone of her big foot, so this joint right here on her foot, instead of sitting there, was sitting here like this. Your toes were in here. That was the big toe joint right there. Her foot was just shaped like that permanently and just kind of like that, warped into a point. And then I think that was when I was like, I am never wearing high heels again. Because she had worn them for years.
I don't know why people wear ladies wear high heels. It's like it's not even good for you, right?
No,
like the feet is like this.
When they've
right?
done wear modeling, so modeled how it wears the body, they found that it increases risk of arthritis in knees, actually.
Oh my God, this is getting worse and worse.
But it's because you can't slouch when you wear them, so you have to have good posture. You have to tuck your core in. You have to, tuck your posterior in, and that's why. So you have to have your muscles tight because if you try to be floppy, you fall
So as soon
over.
as you said that, I changed my
Right?
composure.
You're
Like, oh God, I
Yes, but see, you're imagining what high heels would be like.
hope I never have to.
It'd be interesting. They make tons of sizes now.
For men?
For everyone, and different widths. And again, Eravon, which is Dunham's brand for women, and they do sort of dressy-ish shoes.
Yeah.
They make shoes that would fit
Yeah.
you in women's.
I'd rather no.
You'd be about a women's 12,
that will never happen. I'd rather
12.
Last time I saw that, I
wide.
chopped my foot.
This is I don't know. You could have some really cute little
No, don't even.
Mary Janes or something. Be good.
Oh God. We talked for so long. Can you believe that? We talked like look how long has it been? The time.
I don't know.
Where's your watch? Didn't you have a watch on?
No.
Okay, good. I don't wear
I don't
watches.
usually wear watches.
I don't. Why time is like a slavery, right? And you have to work so much. It doesn't matter how much.
No, I drain the batteries.
Are you serious? How?
Magic. I've gotten my watches fixed because I'll put a new battery in, I'll wear them for a few days, and then they just stop. And then when I take them off, they
Yeah.
start again. So
Yeah.
I've taken them like 3 or 4 times to the
Yeah.
watch repair, being
Yeah.
like, my watch doesn't work.
Yeah.
And they're like, well, just put a new battery in. Like, no, but I
Yeah.
did.
We talk about it in a bit. So maybe let's close this up.
Mm-hmm.
Anything else you want to talk about? Where's your website? How people can get a hold of you?
So it's edgeorthotics.ca.
Yeah.
So if someone has extended medical, they should get a referral from their family doctor
Yeah.
or walk-in clinic or whatever.
Yeah.
And we do the half-hour consults. And our receptionist can go over, she goes over, there's a consult fee and then the cost of orthotics if they're needed, and all that kind of stuff. And we always tell people to bring their shoes so we can make fun of them. It's,
you know what? I love being made fun of because
Yeah,
I
see,
learned so
good.
much. I learned now I don't know what to do. I have so much shoes now.
Yeah. Well, I mean, go through your shoes because some of them
No,
might have those.
I have I think I have 10 pairs. I don't think they probably last 1 year and a half maybe if I'm lucky.
Yeah, go through them. Because, I mean, that shoe maybe
Yeah.
for the first month it was good and then you just have to replace it more often.
Yeah.
But yeah, just something ugly.
I should
Uglier
make
is better.
I should sign up in the shoe company. Every 2 months I get the same
New shoe. It's a subscription service.
Yeah, that's what I was gonna say.
Yeah, but then 4 times a year they're like, oh, well, we changed it just a tiny bit. Now it doesn't fit the
It
same.
keeps going. So talk about your website. Where can people find your website? Where is it?
So yeah, it's edgeorthotics.ca.
Yeah.
So I named it because I figured Edge is my last name, and I
Yeah.
figured that was a good name. for the company because it's fun. No, yeah, so it's edgeorthotics.ca, and we're located in the Park Hill Center.
Yeah.
We have the giant sign if you come in the parking lot, because when they sent me the picture of the sign superimposed, they're like, "Is this good?" And I said yes, because I thought they were scaling it.
Yeah. What did
But
they
no,
do?
that was exact. They were being literal, and I was like, "Oh, that's huge. Okay, that's okay."
Perfect.
But yeah, and then we have there's two podorthists there, and we book patients Monday, Tuesday, Wednesday from about 9 to 4:30, and then the orthotics are ready the following week. Or if like when there's a flu going around or something, and a lot of people cancel, sometimes they're ready later that day. Just because when you have the lab right there, if you don't have patients, you just work in the lab. You always have something to do, right?
Yeah.
None of this sitting around being like, I'm so bored.
Nobody's bored here.
No, right? You always have, you can just build orthotics or clean the lab. It always needs cleaning. It's very dusty.
Okay. Perfect. Thank you very much for coming on the show.
It's nice meeting you.
Yeah, Sammy, it was very interesting. I learned so much. So we're going to end it. I'm just going to say goodbye to the audience. Thank you very much for joining us on this episode of Northern BC Narrative on Location. I hope that you learned a lot of stuff about your feet, your shoes. I learned a lot today, right? And see you on our next episode. Good.